All right. Good morning, Dr. Burhenne. I'm very excited to have you on here. It's a little bit early for you,
Oh,
Pacific time, but thank you for taking the time to come on here this morning.
thank you for having me. And it's never too early to talk about airway-centric dentistry and functional dentistry. So no problem.
Yeah, well, you kind of started the first question I wanted to ask you. Let's dive right into your journey from traditional dentistry into functional dentistry.
Yeah, I mean, I wish I had gotten all this in dental school. I wish I had gotten myofunctional training in dental school. And unfortunately, that just doesn't happen, even to this day, to a certain extent. But again, as you come out of dental school, they say you're a safe beginner, and I would agree. But there's a lot that you don't know, and to be fair to my dental education and to your education, we learn the best stuff when we're practicing, and that's why they just want you to be a safe beginner, and then you keep learning. And so it really happened. So my transition from being a conventional dentist, which there's nothing wrong with. I mean, Western dentistry, the dentistry in the U.S. is amazing. It's amazing what we're able to do. We've come a long way, but we really have been kind of standing on the sideline in terms of the functional approach, and that is finding out what is the root cause of all these diseases that we're dealing with. It happened for me. It happened. My eyes opened literally with sleep when I got a sleep diagnosis, mild sleep apnea. My wife got a diagnosis of severe sleep apnea, and we're both healthcare professionals, and it really kind of threw us for a loop because it really wasn't on our radar, and again, we had no training in it, and it explained a lot of my oral health issues, clenching, grinding, narrow arch, breathing issues, which I consider to be a dental issue. Typically it is. So just by learning that, and that was in my early 40s, it happened. Interestingly, we were dropping off our oldest daughter at college. So all five of us, my three daughters and my wife and I, were in the same hotel room. And the next morning I woke up being beaten up with pillows, my daughter saying, "Dad, what was all that noise?" And to make the story very short, it turned out that both my wife and I were snoring. And as you heard, we both got diagnosed for sleep apnea. And that's when I realized that, my neck pain was not from doing dentistry, in this position. It was from lifting my head off the pillow because I couldn't breathe. It was my posture. My wife has C1, C2 issues that she was able to resolve, but not until after we fixed the sleep. So talk about a root cause of a lot of things that we thought were just aging, and no, it wasn't. So of course that changed my whole way of thinking, and I think functional dentistry is really the future of dentistry. It's really where it needs to go, and I think there's already been a movement towards that. We have a list of we have a locator list on our website, Ask the Dentist, and it's on the upper right-hand corner. It's Find a Dentist, and really it directs you to a functionally minded dentist. And that's a dentist who, instead of getting cavities every 6 months or every 12 months, they're going to he or she will address why you're getting them, and there's no reason why you should be getting cavities.
Right.
Also, is your dentist looking at whether you have a tongue tie? Are they looking at whether you're having breathing issues? This really is under the umbrella of dentistry, because for example, and I think you got this in your training as well, we get exposed to facial development, that lower face and how it develops. And I just threw away my textbook because it was out of date 35 years, 38 years ago. But the point is that I had a textbook in dental school about that. So really, since we're the only ones that are getting the most in-depth information about that, we really should be treating and diagnosing and screening for airway issues, because, as you know, it's all related. Most of it is related to development of the face. And so that's the big functional umbrella. That's the largest one in dentistry. It's if we truly are in charge of this, then we have a broad scope to look at and to treat, and that is sleep.
Right. And, I feel like I remember back in hygiene school learning how, we'll see different things in the mouth. If the patient's a diabetic or it's heart disease, it's going to affect, their rate of the periodontal progression and all of that. But it's they don't really obviously teach you that whole connection and how it's almost kind of the reverse. So let's talk a little bit how dental health affects every system in the body.
Yeah, it's the it's referred to as the oral systemic connection. Most systemic diseases have some oral component to it. In fact, you can usually end up finding a oral bacterium associated with that disease.
Mhm.
Alzheimer's, diabetes, even cancer. Alzheimer's is a classic example. Gum disease essentially leads to and can be a causative factor of gum disease. We just discovered this, the gingipan, as you know. These are things that if you have a fire going on in your mouth, inflammation, this passes on through the rest of the body,
Right.
metastatically, through inflammation, through injury. There are multiple mechanisms, and we don't fully understand it yet, but we do have plenty of studies that indicate that you're not healthy unless you've addressed oral health. And the stats are staggering. Correct me if you have different numbers, but gingivitis, 80-90% of the US. I mean, that is the first stage of gum disease. I would
Right.
say full-on perio with bone loss, 40-50%.
Mhm.
Maybe a little bit less than that, but I mean, that's a pretty prevalent disease. And of course, another oral disease, cavities, that's the #1 disease in the world.
Right.
It's the most common disease in the world. And our ancestors didn't, it was the exact opposite.
Opposite. Yep.
And we didn't have that for a variety of reasons. And again, this is the functional approach, looking at what is the root cause.
Mhm.
But there's definitely, to answer your question, there are definitely connections between what happens in the mouth and what happens in the body, and it's all connected. And
Right.
unfortunately, physicians are practicing in their little vacuum, and dentists are practicing in their little vacuum, and the two really coincide. I mean, it's not just a little subset; they are one
Right.
and the same.
1000%. We need to all work together. Let's talk a little bit about the oral microbiome and, different tips that you have for a healthy oral microbiome and even how you can reset it.
Right. So we do have a product on our website. We're actually revamping it right now with more videos. And it used to be called an oral microbiome reset. Now
Mhm.
it's an oral health reset. And let me just back up a little bit. So the oral microbiome has taken center stage, as has the gut microbiome. Most people know about the gut microbiome, but they don't know that there are other microbiomes. There's
Mhm.
a skin microbiome, there's an armpit microbiome, vaginal. Uh, I mean, uh, s- um, there's so many. And for dentistry, it's the nasal and oral microbiome. I just call it the oral microbiome. And this is something we've been mistreating. We've been treating it very poorly with mouthwashes and disinfectants. And I think we have this model in dental school of it being a dirty mouth, and we're always trying to, do the opposite, where in fact, it has viruses in it, and protozoa and parasites and fungi, yeast cells, and bacterium. And a lot of them are our own bacteria, but a lot of it is bacteria that are not, human DNA. And just like the gut microbiome, and this has a reason, it has a purpose, and it's to protect this. I wouldn't call it fragile, it's not, but this unusual part of the body where it's open half the time. I'm talking a lot right now, and there are a lot of things entering. We breathe in, we take food in. I mean, this is a very unique part of the body. We've got
Right.
inanimate objects piercing through the body, teeth. That's a very as you know, as a hygienist, that's a very complicated kind of system where you're trying to prevent those bacteria from entering the body with these inanimate objects coming through the gum, teeth.
Mhm.
And that isn't really, fingernails are not the same. It doesn't happen anywhere else in the body. So it really, the oral microbiome is very important. We have to preserve it, nourish it, feed it. We've been carpet bombing it with Listerine and alcohol and ethanol, not ethanol, but pesticides, triclosan, detergents, antibacterial soaps, essentially. Then we've got all these surfactants, emulsifiers, and toothpaste
Mhm.
that literally they're there to make a big batch of toothpaste so that it mixes properly. I mean, that's the necessary evil of manufacturing,
Mhm.
toothpaste manufacturing. But a surfactant, I mean, the way it works is it breaks down the cell wall, and it's a lipid. It breaks down lipids, which is what soap does.
Right.
That's how it cleans. So that's not good for the oral mucosa, which is it's a 1 cell thick membrane that is permeable. It's not good for the tongue. It's not good for the tissues of the mouth. So the mouth is under attack. This oral microbiome needs to function because it protects us. It provides us with nutrients. It provides us with the building blocks for remineralization of teeth. So this oral microbiome is extremely important, and it's only really been known to us, I mean, in studies for since I think early 2004 or something. And so this is something that's going to change dentistry, and I hope it revolutionizes dentistry. We have to, as dentists, look at it in this oral complex completely differently. And
Right.
so that my tips for doing that, I mean, you've heard me a little bit talk about, well, no mouthwash. We have a great study out there about how mouthwash actually increases your blood pressure, because it's killing these bacteria that produce nitric oxide. That's the short version. And nitric oxide actually is great for blood pressure. It lowers your blood pressure. It makes you feel good. So you really have to kind of be very careful what you put in your mouth.
Right.
You have to make sure you're seeing a dentist that's not having you rinse with Listerine, although there's a caveat there with COVID. You do have to rinse with a very strong hydrogen peroxide rinse. Some dentists are even recommending a nasal lavage before you go in to see the dentist,
Yep.
just to protect everyone. But I'm talking about on a daily basis.
Right.
These crazy toothpaste did you see Crest just came out with a detoxify your gum toothpaste?
Yep.
I mean, what is that all about? Anyway, my biggest tip, I mean, there are several, but let me just go right to the big one, is mouth breathing. Mouth breathing is bad for the oral microbiome. And I would say at least half of this nation is mouth breathing at some point in time. It could be more. And remember, when you're sleeping, which is 1/3 of your life, if your mouth falls open, even if you're a good nasal breather, which I am, I still have to force my lips closed because depending on what position I'm in, my mouth falls open. That's bad for the oral microbiome because biomes don't like a pH change. And as it dries out, the pH, and of course we don't salivate as much at night. That's a neurological event. Our body doesn't think we need a lot of saliva, which is fine. But it's worse if our mouth is open, we're pulling in all that dry air, especially in the winter. That is essentially leads to a more acidic environment. And then, of course, the anaerobes take hold and a lot of bacteria become dominant. And so that would be my biggest tip. If you wake up with a dry mouth, if you're thirsty at night, tape your lips shut. I mean, it's an easy thing to do. It takes a few seconds. Don't freak out.
Yeah.
It works. It's safe
I
for
was
children.
a lot of the patients will say when we talk about lip taping, and they'll say, well, if I tape my lips, how am I going to drink my glass of water that I keep in my nightstand? I'm like, well, that's the point. We don't need to do that.
Right. And it takes longer to fix that glass of water and bring it upstairs to bed than it does to lean over in the dark and grab some tape and throw it on there. Seriously.
Right? Yeah. Absolutely. Now, a lot of people, like you said, we know about the gut microbiome. Now, a lot of people also take gut probiotics. So if you want to talk a little bit about how oral probiotics are different.
Right. So this is there are a lot of unknowns. As for the gut, I researched into what I should be taking for my gut microbiome. I'm taking a spore, but if you go and deep dive into the data, it's complicated, especially for a layperson. Same for the oral microbiome. You see me sipping water here. I have a mixed, I mix a prebiotic in there in the morning, a little collagen powder. The prebiotic, I think, is just ground up Jerusalem artichoke. Okay. And I figure that's the best time because I don't eat till noon. I haven't salivated all night. I have to hydrate, of course, because I haven't had a drink since 10 o'clock last night. But that's a great time to add pre and probiotics. So pro, of course, is just adding bugs. So a probiotic would be like eating sauerkraut. Due to the fermentation process, there are some bugs like yogurt. The bugs are there and you're trying to repopulate. And prebiotics is the food that these bugs like. So the question is, which do you want? It sounds like you would need both because once the bugs are there, you want to feed them, keep them happy. That does make sense. I think if you have a very healthy oral microbiome and you're eating well, you don't really have to worry about probiotics
Right.
adding the bugs, but because you're eating a lot of prebiotics. But drinking it in a drink in the morning is fine. That works well. Yes, swishing with it and keeping it in your mouth, it's not a bad idea. I just had a conversation with a oral microbiome expert, Cass. Julie Nelson, I'm sure you've read her book. It's a fantastic book. It's really the first book of its kind for the layperson and for dental professionals, actually, on the oral microbiome. And she does recommend keeping it in your mouth. I mean, why not? Someone's got to invent a little pastule or a little pill, not a pill, but a tablet that we can dissolve in our mouth. I think Hyperbiotics does have something like that. My grandchild chews on a hyperbiotic kids version of a I think it's a probiotic.
Okay.
It should be in toothpaste. Instead of adding all that crap that's in toothpaste, add a
Yep.
prebiotic and some probiotics. Why not? I mean, it's part of the gut microbiome system. We're always talking about, feeding the gut. Well, it starts here. It's right here.
Absolutely.
I don't know if I answered your question, but yeah, pro and prebiotics are very important for oral health, and chewing on certain foods and really masticating them and chewing them, breaking it down. I mean, the exposure of that to the oral bacteria, it's fantastic.
Right. Now, you did mention that you don't eat till noon. So are you an intermittent faster?
I try and be typically
Okay. I
five
just wanted
five
to
days
talk.
out of the week. I won't eat till noon or
Okay.
1 o'clock.
So let's talk about, the health benefits to that and how it's not only important, what we eat, but also when we eat it.
Right. So a lot of people have heard about fasting by now. It's pretty, I wouldn't say popular with most people because it's hard for them, but they've heard about it, and there are certainly, autophagy is important. That's where if you starve the body a little bit, and this is a simplistic version of it,
Mhm.
it starts killing off the things that it doesn't need, like the smaller mitochondria, the ones that are weak, and it creates newer things. And this is essentially how our ancestors did it. They didn't have 3 meals a day and snacking in between. They didn't have that luxury. They were walking, they were migrating, they were hunting. It was hard for them to get to their food. They couldn't just open a refrigerator. So there were many times where their diet would vary a lot seasonally, and also it would be very erratic in terms of quantity. But here's the thing. I mean, let me relate it to oral health. And typically things that are good for the body, whether it's a paleo diet or the right kind of foods, there's always a benefit to the mouth because it's connected to the body. It's part of the same system. So intermittent fasting, I think, is very important. One aspect of it for oral health is, it gives, every time you eat something, every time you eat a meal, whether it's a bag of Cheetos or saltine crackers, which is not good, or some raw broccoli, the teeth do undergo a demineralization event. That is just the nature of how things work. And I grew up thinking snacking was the best thing to do, small meals all throughout the day. But I do remember something from dental school. They said, if you're going to eat like a caramel or a candy or have a Diet Coke, do it all at once, right? Because it's the frequency, not the quantity. In dentistry, we're not so concerned about the calories, but oh my God, the exposure to the teeth. So back then, we were talking about shortening that demineralization event.
Mhm.
Well, think about, and of course we know, hopefully everyone knows that teeth remineralize. So teeth will remineralize if your mouth is closed, there's a lot of saliva flowing, and you're not eating. So the longer you can do that, so all night long, your teeth have a chance to remineralize.
Mhm.
If you don't eat till noon, that's a long period of remineralization. And then if you eat from 1 to 5 or 1 to 6, then that's a very short window of demineralization. So I think it's just one way of looking at it. Again, think and do what our ancestors did.
Right.
I mean, there's something to be said for that. And a lot of people push back on that, saying, well, we've evolved to something else. And yes, we have disevolved into something else.
Yes. Not always better.
Right. Right.
So let's talk toothpastes. Hydroxyapatite toothpastes versus what people are normally purchasing, which is the fluoridated toothpaste. And like the way you would explain to a patient who's going to say, well, for all these years I've been coming here and you've been telling me I need to have anti-cavity fluoridated toothpaste, and now you're telling me no more fluoride.
Yeah, that's a tough one. And a lot of patients will push back. They'll think, well, that's, I mean, the benefit of fluoride is very indoctrinated into our society. It's interesting. There's a lawsuit now at the federal level against the EPA and TSCA, which is not completed yet. It was taking place here in San Francisco. I was watching it very closely, and it's amazing how much you have to push back with studies and educated academics explaining to the experts on the other side that fluoride really isn't good for us. So, but in general, we just give the patient a choice, send them to some links as to, and for me, it was always back before I had all the information, back when I was a dental student, when I was raising 3 daughters. I mean, before Catherine was born, I had a distiller in place in our house. And for me, it was a lesser of two evils argument. It didn't make sense. I didn't have enough data back then that fluoride was beneficial. There was certainly a lot of talk about how bad it was. And so I really said, well, okay, well, I'd rather that my daughters have a few cavities rather than have to worry about all those things. And as it turns out, that was a good call, because a lot of these things now we have evidence for lowering your infant's IQ. And I mean, we have 65 studies that support that demonstrate that. Isn't that enough?
Right.
Anyway, but fluoride in toothpaste topically, it does have a benefit, although now and unless you swallow it, of course, that could be problematic. But now we have a good alternative. We have this hydroxyapatite in several different forms. We have a nano-sized, we have a micro-sized. It's been in use for a long time in Japan and Europe. It's now coming to the States. We have toothpaste here in the US now that have it. They're great toothpaste. I think they're much safer than the conventional alternative, the big brands. This is a big market. This is a big moneymaker. It cost Colgate 13 cents to put a boxed, tubed, and marketed piece of a box of toothpaste on the shelves, and you're paying what, $3 to $6 for it. Right. And then you may have 2 at home, one for whitening, one for tartar control. I mean, it's an amazing business, and they're making lots of money, and they're going to be very resistant to changing. So really, the only way it's going to change is if people educate themselves and start looking for better and safer alternatives, which is what the hydroxyapatite is.
Now, is there a certain brand that you recommend?
Right now, I think Risewell and Boca are the two big players with the right amount of hydroxyapatite in it. There are a few other toothpastes that are being marketed by healthcare influencers or their websites, and I'm in touch with all the manufacturers in Europe, and they don't have enough. The efficacy is not there. It has to be at a certain strength. And of course, because it's a cosmetic product, none of this has to be on the label or on the box. So you have to be careful. But I think Risewell and Boca are doing a great job. I have some tooth sensitivity. Boca works great for me. If I stop using it, if I go back to my earth paste, which I love, 3-4 days later, I need that hydroxyapatite. I really do. And it works. It works on contact. So I don't know for your patients, and we've talked about this, where the prophy with the fluoride and the pumice and all that. I mean, there's really no reason to do that, because the biofilm comes back, the pellicle comes back that day. How do you tell your patients that you really don't need this? I mean, and how often are they like, yeah, go ahead, do it?
It's a lot of patients think that that's what the cleaning is that they freak out if you don't do it. I'll never forget in hygiene school when, they taught us only to use it, if somebody had stain, and otherwise it's not necessary. And then the patients that I would not polish, I would go get my instructor, and the instructor would come back and they'd be like, well, she forgot to clean my teeth. And I'm like, I just scaled your teeth for an hour.
That's very interesting that you bring that up. And that's happened in our practice a few times where, I've told my hygienist, you can do what you want, of course. You know what the data is. You can explain to the patient why we wouldn't recommend it. We can spend more time scaling, more time doing oral hygiene instruction. And she was on board with that. They all were. and actually they were happy to do it because they believe in what we're
Yeah.
doing. And then sometimes the patient would forget. They'd call James, our office manager, and say, you know what, the hygienist didn't do a complete job. They spent 99% of the time scaling, and they forgot that 1%.
Right.
And the patient, as you said,
Hmm.
thought, oh, I didn't get my cleaning, which is, it's our issue. We have to educate the patient.
Right.
It's got to
Absolutely.
stick, right?
So kind of going back to what we were talking in the beginning about sleep and airway and everything, I want to talk about your book. So the 8-hour sleep paradox. So I'm assuming your journey is what led you to
Mhm.
writing this book. So if you want to talk a little bit about just the book in general, what it covers for those that have not been able to read it yet.
Yeah, it's actually the bestseller in the orthodontic category
Mhm.
on Amazon. We were surprised. We didn't know what category to pick. It's been out for about 4 or 5 years. It essentially is a 4 or 5 hour read. The reason my daughter and I wrote it, the reason we wrote and published this book is because my wife and I, again, both healthcare professionals. She's a Bachelor of Science Nursing and in biotech and marketing. I mean, we realized that if this journey to get to the solution was so difficult for us, what is it for our patients? I mean,
Mhm.
for the patient. And that
Right.
was before I was treating patients for sleep apnea.
Mhm.
And so, I experienced it myself. So the book really is a how to find out whether it applies to you, whether you have sleep apnea. Lots of little checklists and ways of self-diagnosing, the condition or a loved one. And then there are tools and resources to go to, and it's a book that you can bring in with your sleep physician
Yes.
and discuss things, and that way which way to go. And a big part of it, of course, is the oral appliance and
Mhm.
the dental end of things. And really the conclusion in the book is one of the conclusions in the book is that your dentist in some cases will be able to help you more than your physician can, even when it comes to finding out that you have it, screening for it.
Mhm.
Again, dentists are not allowed to diagnose sleep apnea, which I think will change. And then making that full circle, getting the CPAP, APAP, whether it works or not, that's the question. And then maybe going to an oral appliance or doing both.
Mhm.
But here's the thing: the dentist typically, and I've seen this happen so many times. I've treated thousands of patients for sleep apnea. A lot of the time, this is very common. The physician has done everything properly, good PSG, maybe several, has done some counseling with the patient. They've thrown the CPAP, APAP at them. Follow up on the APAP is not great. It's a technician. Typically, fit is very important, but they didn't address the blockage of the nose, nasal patency, not being able to breathe through your nose. And if you read the studies, compliance of the CPAP is low to begin with, 30%. After the first year, are still using it, still hanging on for dear life. And it's the same for the oral appliance. The efficacy is not very good,
Mhm.
although oral appliance efficacy and compliance is better,
Right.
typically in mild to moderate cases. But if the nose is not online, you can't breathe through your nose, the CPAP's not going to work.
Right.
And so the patient comes to me, I ask them to bring in their CPAP, I have them use it, and I realize that they can't. I usually know that beforehand.
Yeah.
Again, when you lay back your patient and they always have to rinse or spit, you know that they can't breathe through their nose. I mean,
Mhm.
they don't have that other method of breathing while you're working in their mouth. So,
Right.
so it's a no-brainer for us. But for physicians, even ENTs, they don't really address that. So what it means for me is a very strong referral back
Yep.
to another physician, to maybe a different one
Mhm.
that recognizes that, getting that fixed. And then all of a sudden, CPAP is easy. This just happened to my son-in-law. I mean, you have to be able to breathe through your nose for these things to work.
Absolutely. 100%. And that kind of leads me into the next thing I want to talk about, which is conventional versus modern orthodontics, and
Mm,
also really needing to clear that airway and the importance of it, and widening, the jaw and bringing it forward, and not back. So if you want to talk now, I don't remember. Did you have orthodontics in your office?
no, I would refer it out.
Okay.
I referred to an orthotropic practitioner,
Mhm.
even though it was a little far for our patients to drive. But the
Okay.
ones that went, I mean, it was just an amazing transformation. So my thought on that, and again, this is back to dentistry needing to be an airway centric profession. I mean, that's really where we need to go.
Right.
And it's because of this issue. So the conventional, just to explain to your viewers, the conventional, I mean, back in my day, there was only phase 1 treatment. There was only one treatment. It was at age 13. Wait till all the teeth come in.
Yep.
Total lack of regard to jaw development and all that. If there wasn't enough room, well, we take out 4 premolars. We've got an extra set of them. Why not, right? And then just pull everything in and get rid of the crowding.
Right.
But then, of course, the mouth was smaller. There was less room for the tongue. And then early in my career, there was this phase 1, phase 2 approach, which we thought was great because, the referrals were earlier, but the referrals are not early enough in that phase 1, phase 2. And so essentially now, I mean, for the last 10 years, I've been referring kids at between age 1 and 2.
Yeah.
My youngest daughter got treated at age 5 for a class 3. So, I mean, really, development is done. Facial development is mostly done by age 6, 7, 8. There's a little phase after that till maybe 10. But if you haven't fixed the root cause for the crowding, and there's so much pushback from conventional orthodontics, and they hate it when I use the word conventional orthodontics. It is very conventional. Yeah. And it's because it's a big business and their business model is working very, very well. And so there's a lot of resistance, but there are many orthodontic pioneers right now. There's one in England, there's one down at UCLA, there's one up in Chicago, New York, Bay Area, we have a few, Seattle. I mean, but the problem is that everyone's got their own name for their device, for their expansion device. Everyone's got their own name for what they're doing. It's essentially the same thing. It's the right thing to do. Dentistry needs to get locked in, have one big broad umbrella of this early, I don't want to use that word, but proper treatment schedule and referring at an early age and dealing with facial development issues. And then what are the root causes of this? It's tongue tie, it's midline defects, it's nutrition, diet, it's the epigenetics, our environment, air pollution, not being able to breathe through our nose because we're congested, allergies. So people are doing this, but I feel bad for the patient because typically they don't know where to go and their dentist doesn't know where to refer them because they hear about it on a podcast like this. Right. So it's still very disjointed. And I actually see a lot of the conventional orthodontists really making fun of these pioneers. And that's going to flip-flop soon. It's going to take 10, 15 years.
You made a good point, though, that there's so many different appliances out there with different names that essentially do the same thing. And that's probably hurting the progression of this because those that are still more on that air quote conventional side are probably thinking, well, they all swear by theirs is the best. Right. And instead of taking, 3 of them and looking at the science behind them and all of that and coming to the conclusion, oh, wow, these really do all do the same thing. And I mean, I get it. You have to market. It's still a business and you want people to buy into yours. But at this point, we just need people to buy into the overall idea of what these appliances are doing. So I think when we had met a couple of weeks ago, I think you said this, that it's not so much the appliance, but the provider and what the provider is going to do with that appliance. Exactly.
And dentists, as compared to physicians tend to work in hospitals and maybe under the umbrella of a university. They work in group practices, where dentists typically work alone. And so they tend to be more, they're mavericks. I mean, they're not really, so that's why this happens, this disjointed, everyone's kind of trying to get to the same result, but we all do it on our own. So we really need to, as a profession, we need to get together on this topic and become airway centric oral health care providers.
Because I find the other struggle is, when I have a patient come in and I'm making a referral to an ENT, back to their dentist, back to a release provider, and the parents of the children are looking at me like I have to go see all these people. No. And like, yes, unfortunately, it is what it is because we're not just wanting to straighten your child's teeth. This is about their overall health. Right. But you need that supporting foundation from all of these providers so that when you're making these referrals and they are going, you're all saying the same thing.
Right.
Because if not, the patients are just, they get
They get
frustrated,
very,
but you can't blame
yes.
them because it's a longer process and it's more involved than,
Right.
I didn't have braces as a child, but my brother did, and my brother probably could very well benefit from myofunctional therapy, and none of this stuff was talked about. I mean, he's a mouth breather, he still is. It was never brought to my mother's attention, the negative consequences of that, or why he developed, with a longer face, and he's got that flaccid rolled out lower lip. He just was off to the orthodontist, and they straightened his teeth and called
Right.
it a day.
Well, you bring up a great point, that confusion with the patient, because we're so disjointed,
Right.
it carries over. There's another effect. It carries over to the third party providers, the insurance companies. And if
Mm-hmm.
they see that disorganization and everyone's kind of doing their own thing, then they're less likely to cover procedure. But if we got our act together and
Right.
really had one kind of approach
Mm-hmm.
with multiple devices, of course, and all that, but it was all more homogeneous in
And like the flow of
conceptually,
it all. Yeah.
right? Then the third party providers would see, well, okay, if we intervene now, then there's much less downwind that will happen downstream,
Right.
like sleep apnea or
Right.
extensive ortho or orthodontic surgery, and that would save them money. And these are
Yeah.
procedures that they cover now, but if they would just move upstream a little bit and cover facial development issues and early intervention, which is
Mhm.
cheaper and a better way to do it,
Right.
then they would save so much money on the back end. And then the other problem, of course, is that dental insurance and medical insurance are separate entities. And because that's the case, that is unlikely to happen at this point in
Right.
time, because they see them as two different parts of the body, which
You said
is
the same thing.
absolutely it's costing us billions of dollars,
Yeah.
that reason alone.
Absolutely. Um, Thank you so much for all of this. This was absolutely amazing. Is there anything that you want to leave the listeners with? Any health tips, sleep tips, anything at all you want to leave them with before we wrap things up?
Boy, how much time do you have? Well, let me just say that I think people that are listening, they like what they're hearing because it makes sense to them. But the problem is then they're going to go see their dentist or their physician, and it just stops there most of the time. So I would encourage your listeners to reach out to a functional dentist. And again, as I referred to earlier in the show, we have a list of functional dentists, over
Yes, and I
100.
will link that in the show
Okay,
notes,
yeah,
the
that's the
website.
functional provider list. It's on our website. I would tell them to read my book, even if you don't think you have sleep apnea. I was actually talking to a dentist, a wonderful guy who's on our list, implant guy in Iowa, and he's young, he's fit, and I had him get one of these Aura rings because his
Mhm.
father has sleep apnea, and it turns out he may have sleep apnea, and he was very surprised. And of course, now he wants to get into sleep, just like what happened to me.
Yep.
I told him to join the AADSM, which is a great organization. But I mean, really, most of us, and I was in the same boat, most of us don't think we have a sleep issue, even though we're tossing and turning and making noise at night. And I would just say, my last tip or comment would be, remember that most of us are not able to breathe properly. And so it's not the other way around, where there are some of us that can't breathe properly. So think about that. The implications are huge. And there's lots of information out there on the web. They can read my book. They can listen to your podcast. There are plenty of other resources out there. Start boning up on it and find out where you fall on that scale.
And you're never too old either to
Exactly.
fix all these problems.
True.
I have a lot of patients in their 60s and they're like, it's not too late for me. Like, I didn't miss the boat. I'm
Right.
like, well, yeah, it would have been greater if we caught you when you were younger,
Right.
but no, you were not too old.
Yeah.
My partner and I were lecturing the other night, and one of the women's questions at the end during the Q&A was, is adult expansion really a thing? Yes.
Yes.
Yes, it is. It's not
Yeah.
the easiest thing in the world, but it's doable.
Right. Actually, the ones that I've seen, I love treating 85-year-olds for sleep, and there are only a few of them, because at 85 you're like, okay, this is how it's been. I'm just gonna do the best I can. I have a patient who, I think she was 84, 85 years old. She had an AHI of 74, and she was given a CPAP. Of course, it didn't work. She couldn't breathe through her nose. So about a year after we treated her with an oral appliance, which you're not supposed to do with that severe of of a AHI scale, but I had her promise I had her sign the chart asking her that if we made the oral appliance, we got her down to 19, by the way, which was
Oh,
amazing. Then she would go back to the CPAP, or actually get an APAP, get it
mm,
recalibrated, and the two together worked much better. Think of all that air being pushed in to open up someone that has an AHI of 74.
yeah.
And she considered surgery and expansion, didn't want to do that. But those are some of my favorite patients, because late in life, they have this kind of awakening. Sorry, bad word. I mean, pun intended perhaps, but they really, they're like, I mean, they just get it. They sleep
Yeah.
better. They don't toss and turn at night. They feel different. They take fewer meds perhaps. So their
Mhm.
GERD goes away, and
Yep.
they start bringing in pictures of their grandchildren. I mean, it's just a new lease on life, even though it's very close to the end of their lives. So
Absolutely.
I agree. It's never too late.
Yeah, 1,000%. It's awesome. Again, thank you so much for coming on. This has been fantastic, and we will definitely chat soon. We'll have to think of another topic to talk about, because I'm sure
Oh,
we
there
could
are
talk
plenty.
probably all day on here.
There'll be plenty, and I look forward to it. Definitely, let's do that.
All
Thanks,
right.
Amy.
You're
Okay.
welcome.